To recap, last week, we like to give a little refreshers of what we learned from last week. With the social determinants of health, we were reminded that these are conditions and environments where people are born, live, learn, work, and play, worship, and age, and it affects holistically a wide range of functionality, quality of life, and outcomes. And we want to be reminded of some of our unexpected microaggressions. One of the things that I'm always reminded about is, understanding, I don't know if it's so much the social determinants of health, but certainly with our cognitively impaired older adults, how they always take cues from facial expressions. And we'll see a little bit of that in our presentations about, making sure that you used raised eyebrows rather than furrowed eyebrows when addressing an older adult with memory impairment, because the body language is actually 60 to 85% of all the communication. In terms of the lessons learned with action steps for the quality improvement, is that we want to gather data from multiple sources. We'll hear a little bit more about that and build on that today. These can include elements such as satisfaction surveys, other surveys of residents. We mentioned previously that we had a survey that was called the UCLA Social Isolation Survey. The previous time we did this video series, we found that close to 2/3 of those older adults surveyed in long-term care had expressed some elements of social isolation. And then also just to remind us that we want to utilize these data sources on a regular basis, try to set goals related to that data. So, the most obvious ones tend to be like falls. So if we have a fall rate of 100 falls annually per 100 residents, or whatever metric we're using, that we then set a goal to maybe reduce that by 10%. And that would be our planning cycle, for the plan, do, study, act cycles. And then finally, just get the team involved. And again, using all staff. My favorite was to use our dietary staff, in our quality improvement meetings. They always came up with some great ideas. And, we reduced dehydration in the nursing home by having a soup wagon go across in midday. And they had 3 different kinds of soups that the residents could select from. And then we also regularly offered water for those that didn't have any restrictions on water, because we knew that people, particularly the cognitively impaired, don't always remember to drink water on a regular basis. Next slide, please. Okay, so I'm going to hand off to Carmen Bowman, our culture change expert extraordinaire. So Carmen, take it away.
Thank you so much. So everyone, it's kind of challenging to to be given this opportunity. And so I'm going to pass the challenge back to you and all of us. If I could have the next slide, please. And what I mean is, I get a moment here at the beginning to kind of challenge ourselves to move in the direction of changing institutional culture. That's what culture change means. And one way to do it is with language. It's a kind of a great place to start, and something we all can do, and it costs no money. And so I want to show you a quote from someone who moved into a nursing home once that kind of depicts what we're doing here. So this woman says, "It would be nice if when a person moves into a nursing home, they ask him or her, 'How do you want to live?' and not just all that medical stuff." Isn't that great? And I believe it's a great reminder for all of us. You've heard me say this, and I'll probably keep saying it, is what lens do we look at this place? It could be an assisted living as well. Do we look through the lens that that's where I work, and I'm the director of such and such, and therefore I have to be very medical and very clinical and very professional? And that's where some of these institutional words come from, right? But if we look at it as a house and a home where people live, just let that guide you. Go with your gut, go with your heart, go with normal language. And notice she is talking about, let's talk more about how we live. Instead, notice she doesn't say, tell me how you want me to take care of, me. And so it's that point again about talking about living in life, maybe even more than care. And if I could have one more hit of here we go, look at this, on the point of language, everyone. What would be natural if you are moving in and out of a place to live? Are you admitted to that? Were you admitted to the house you live in? Were you discharged from the last house? And notice she just uses it naturally here. So that's another word to add into our vocabulary. And I just challenge you all. I don't mean to pick on anyone speaking today, but as you wish, as you can, keep moving in this direction.
So today we want to take a look at this question of what we call age-friendly health systems. Age-friendly is a concept that has emerged over the last several years to help embrace a concept of fundamental geriatric practices of healthcare. And as we'll see, they revolve around 4 different topics. They would call them the geriatric 4 M's. And when these 4 M's are applied on a consistent basis, there's vast improvement in the clinical outcomes for older adults. And so that's why there's this whole age-friendly health system certification process. We'll talk a little bit about that. And also how your facility can become certified as an age-friendly healthcare facility. And this is through the Institute for Healthcare Improvement. They have you sign up and you meet certain elements of this in collaboration with your primary care providers, and then you can get certified and advertise with this logo as a age-friendly system. So let's have the next. So this whole business of age-friendly healthcare is guided by evidence-based medicine. It's intended to avoid harm, which is most importantly, and it focuses, as I mentioned, on the geriatric 4 M's. Next slide, please. These are the 4 M's, and they have nice little logos and symbols with them. We're even using this in our clinical charting these days to try to quickly identify which of the 4 M's that we're talking about, but they're basically surrounding what matters, medication, mentation, and mobility. Now, I have a disclaimer that in terms of cultural sensitivity that we've been talking about, mentation is not always the best term to use, particularly with American Indians. Our Native American elders prefer, by some of the surveys that we've done and feedback, prefer the M of using mind, M-I-N-D, because it connects more body and mind relationship as opposed to mentation, which has more of a pejorative term. And I'm happy with that. Body and mind is, I think, a very important, and that's exactly what this is. Between mobility and mind, those would be definitely part of the relationship. And we'll see how these are all intertwined. However, today we're going to focus on what matters. Next slide, please. So the concept of what matters is to really know and try to align care with each of the older adult's specific health outcome goals and care preferences. A lot of times I can tell you from a physician's point of view, it's always this finger wagging, you must do this, and not necessarily, do you want to do this? So it's important for us to understand those preferences that older adults have and try to align the care with that. As an example, in my clinic yesterday, I had an 88-year-old woman who says, my sister just found out at the age of 90 that she has breast cancer. Should I have a mammogram now? And she hadn't had a mammogram for 15 years. And the answer was, well, depends on what you want, but the recommendations are such and such. And so she wound up declining, a further evaluation, but it was based upon what mattered to her, as opposed to just meeting some sort of arbitrary guidelines. Next slide, please. The term of, when we talk about the form of medication, basically we want to get rid of a lot of these bad medications, and sometimes things like amiodarone affect mobility because they make the person tired and fatigued. So we need to consider that, and we'll talk a little bit more about this in the following series. So why don't we move to the next slide. In terms of mind or mentation, we want to deal with the 3 Ds of dementia, depression, and delirium. And I often say that as we look at these wonderful portraits of these four older adults, we probably could not predict which one has dementia. It's like a lot of times they have this characterization of who looks demented, and they always look like they're frazzled or unkempt or not put together. When in fact that's not true at all. And the other fact is that 50% in rural areas, 50% of individuals that have some form of cognitive impairment go unrecognized by their primary care provider. So just think about that for a moment, and how we can prevent the progression of Alzheimer's disease if we're not even recognizing early cognitive problems. Next slide, please. Mobility is a huge issue, and of course we relate that to falls, and this is the steady toll that we're seeing from injuries and deaths, traumatic brain injury that are related to falls. And this is happening across the entire population. This is just not in long-term care. There's been a 150% increase in falls in the older adult population over the past decade. So something's cooking, and we got to figure out, why people are falling more and getting injured more. Next slide, please. Yeah, so we can see in our areas here that we've got, the participating states here: Montana, Wyoming, Utah, Colorado, North Dakota, South Dakota, that we have a pretty high fall rate across the board. And I just want to point out just our North and South Dakota participants that there's a nearly 1.5 times greater mortality from falls here in the Great Plains compared to the U.S. average. And I can't exactly explain why that is, but I think it's a challenge for us to contemplate and try to address no matter what the setting is. Next slide, please. So I just mentioned about becoming age-friendly. So one is here, we're learning about it through this introductory slides. And then what you can do, the Institute for Healthcare Improvement, if you just simply go to IHI.org and then enter age-friendly into their search engine, it'll draw you to the registration where you can enroll in that. And if anybody wants to enroll in the age-friendly healthcare system, I'm happy to have a one-on-one meeting with you and your team to discuss what's required. And I have some forms that can be used in that process so that you can get certified. Next slide, please. So to move into what matters, next slide. What matters really depends on the status of the individual. You've got the highly functional individual, the person perhaps in long-term care that's recovering and planning to go home. And then you've got people who are frail, who may not make it back home and will continue to reside in a sheltered setting. And so the preferences for these folks may be different based upon their functional status. Next slide, please. And we have to recognize, again, patient-centered care, resident-centered care, older adult-centered care, however you want to word it, that there are individuals that are highly invested. They want, for instance, tight glucose control. The SPRINT study tells us that we should have strict blood pressure control if you're highly functional. The targeted blood pressure of 120 systolic rather than 140. And then there's the laissez-faire, kind of more what we call loose glucose levels and less strict blood pressure. And a lot of that depends upon the patient preference, in addition to advice from the primary care provider. Next slide, please. Some of the care preferences depend. So, for example, medication regimen. Maybe the burden of 10 pills is just too much, and perhaps the individual doesn't want to take that many pills. So it's incumbent upon us to figure out ways to reduce the pill burden. Also, in terms of healthcare visits and in terms of long-term care, whether hospitalization even makes sense. And so those are the kinds of questions that need to be asked under the rubric of what matters, that if you got very seriously ill, would you want to go to the hospital, or would you like to be taken care of here? And And so if the capacity is there for taking care of an acutely ill individual, then so be it. So that's trying to put lockstep into care preferences that rather than just like this automated, oh, you're hypoglycemic, you're off to the hospital. Next slide, please. So some of the problems with trying to figure out what matters to the residents is that the providers don't have time to figure that out. We don't always ask the older adult, like, what one thing about your healthcare can we do to help you do blank? And it may be something like, I'd like to go bird watching every once in a while. Well, what do we have to do for that? Or I'd like to see my grandchildren. What do we have to do to get you, to be able to see your grandchildren? And trying to make these alignments with the healthcare plan, with the objectives, the life objectives of the older adult is what alignment of healthcare means in terms of what matters. But we don't have the time always to do this. And so it's an iterative process. It's something that we have to do on an ongoing basis. And then also the difference between patients and families is that, they may not think about it. I mean, I asked somebody in my clinic, an older adult, and I said, what really matters to you? What do you want to do with your life? And she looked at me very strangely. And she says, my gosh, I've never had a doctor ever ask me that. And so there you go. And the doctor should be asking that. And that's under this framework of the 4 M's that should be front and center before you move on to the other M's. Next slide, please. Some of the pitfalls are, what matters is that people's health change. I mean, we've seen this with the COVID pandemic, and we're not always prepared or advanced or expecting to get COVID or to get as I saw a lady in clinic the other day, respiratory syncytial virus. As I could tell people, not everything's COVID, right? People do get sick from other illnesses, respiratory illnesses. So you've got these rapid changes that you need to address. And then you've got the chronic changes, such as the more indolent aspects of memory loss with Alzheimer's disease. Next slide, please. A lot of times there's ambivalence towards figuring out what matters is because, there's this, you've got this ambivalence, they're not really sure, you don't want to be bothered. Nobody's asked the questions. And so this is all trying to create a culture of identifying what are the goals of older adults. And then sometimes the interference occurs with mood disorders. People are not as motivated to do something because they say, what the heck, I'm here in the long-term, I'm here in the nursing home. I mean, this is the end of the line for me, which may not be true, right? And so the whole question that we haven't talked about is how do we estimate average life expectancy? And just as a heads up, the answer to that last question was that it's a 2 to 3 year period between when people become functionally decline and when they die. And that really holds up no matter what age that they die on, unless it's a sudden death episode. Next slide, please. Yeah, so anyways, the what matters is that folks don't think about their own mortality. They don't think how much remaining life expectancy they have. Family members always overestimate it. They always go like, 5, and that was the answer to the first question. Family members typically think that their family members have 5, maybe even 10 years of extra life expectancy, when in many times it's only 1 or 2 years. Next slide, please. And this is just reemphasizes this slide here that it's a 2 to 3 year period between the dotted line and the dark line, which is the difference between a functional decline, or what we call functional life expectancy, and then absolute life expectancy. Next slide, please. Yeah, we all know that documentation is not great. I mean, I think long-term care facilities, like, well, we have 100%. We've got the pulse. We've got the advanced care directives. That's not really what we're talking about. We're talking about documentation of a more descriptive what matters. And so the maturation of a mature what matters representation in the healthcare records are a dialogue that indicates what the patient wants, not so much what they want in the acute care setting, or in this sudden death setting, as I call it. So these advanced care plans and the pulse, those all relate to what happens if my heart stops, what happens if I stop breathing. In the context of what matters, we're asking a more far-reaching question as to how we can get you to the goals that we want to get you to, or help you get to the goals that you want to get to, I should say. Next slide, please. Yeah, so a lot of this is, you can see Leonard Nimoy here in his just pre-morbid state here. He died. He was a smoker and died from lung cancer. For those who are Star Trek fans, but basically, the framework for what matters is to really recognize when medical care is futile, and to be able to express that to the older adult. Things like intubation, CPR. For instance, in the veterans system, there's a 0% chance of survival in the intensive care unit if you need CPR, and that's what the research supports. Next slide, please. So it's important to, again, establish the priorities, and then we want to better integrate care to meet those priorities. Next slide, please. And there's this website here of patient care priorities that I can refer you to. You can just Google this, and it'll give you, this is actually for nursing and providers and social workers to help understand when the benefits outweigh the interventions. Next slide, please. So just a quick thing here. If you look at somebody, and if they look older than their stated age, then pretty good chance that they are older biologically, and that can help inform your estimation of life expectancy. And that also, you can go to ePrognosis, which is an online calculator for estimated life expectancy. Next slide, please. Yeah, and this is just a reference to ePrognosis. And next slide. These are some questions. I'm not going to go through all these, but this is how you start to ask the question of what matters to the older adult, and you'll have reference to the slide deck to take a peek at that, just because I want to be mindful of our time here. Next slide, please. We know, I think, are familiar with the physician orders for life-sustaining treatment. Just interestingly, 80% of people who show up in emergency rooms reverse their pulsed elements, and the other 20% that don't can't speak for themselves. So gives you an indicator of how much energy we put in the pulsed, and then they all get changed around, at least in the community setting. Next slide, please. This is a big one. You might want to adopt this. This is called the Stanford letter. This is the letter to the provider. And again, you can do this online, you can do it on your cell phone, or you can print this out. And this is a good starting point. I just really like this letter to the doctor. And it could be a letter to the facility for that matter. Next slide, please. And then, of course, trying to advise patients, and certainly letting them know about, and the family to know about their remaining life expectancy, I think is really, really important component to this. And again, I refer you to that bottom Stanford letter website. So you just type in Google Stanford letter, and that should bring you to that. Next slide, please. And just as a referral, so I mentioned the Institute for Healthcare Improvement, and this is from their website. They have the toolkit of what matters to older adults, and so that's a point of information that you can peruse and learn a little bit. Just to summarize, we want to focus on what matters, and we want to do a coordinated effort to establish what matters to the older adult through something like the Stanford letter.
8, identifying your gaps and opportunities. Next slide. This is where okay, so this was the homework from last week, which was to share some successful strategies for collecting your QAPI data and a story of how you've used your QAPI data. So I believe we're asking you if you want to slip that into the chat. We can have some good dialogue, hopefully, on what you've been successful in using your CWOPI data and your CWOPI plans. Next slide, please. And then this is follow-up from last week's sessions. We asked you to check out resources, including the CWOPI at a glance. So we're, like I mentioned, we're talking about step 8 today, which is funny. I presented for you on data, which that step, which I think was 5, and this step 8 really overlap quite significantly. And so we'll kind of cover that ground, and I think some of it will be just reinforcing the steps, how they reinforce and complement one another. So again, we want to bring our focus to transforming the lives of our residents with continued attention to our care and the quality of life. And we're really focusing on person-centered, person-directed care, which, you know, we say all the time, talk about all the time. Next slide, please. So this was just dropped in as a I guess 10,000-foot view of how CWOPI has developed in our nursing homes. I guess the point is that it's really not new, although it came significantly on our radar after the Affordable Care Act in 2010 as a requirement for us. Next slide. This is just pointing out for us probably some reinforcement about the key differences between QA or quality assurance and performance improvement. I'm not going to read through this either, but really performance improvement, I think, is where we're going to focus most of our attention. Is you're preventing harm or events, and you're being proactive instead of reactive. Next slide, please. This is just dropped in to kind of give us, again, the big view of where we're at, the elements of a CWOPI program. Next slide. So the meat and potatoes. In step 8, we're identifying our gaps and opportunities. Here's really where we're overlapping with our data systems, our data collection. So there are lots of areas where we might be able to collect the data in order to identify our gaps and our opportunities. So a gap is going to be sort of a process that broke down or an event that's going to lead to problems. Whereas opportunities, we're looking for where are opportunities for improvement. Our opportunities may come from gaps, but we also might identify something that hasn't become a problem yet, but maybe we're seeing a pattern that we're concerned about. So we're looking at our MDS, we're looking at patterns within the care that we're giving with our caregivers, looking at any kind of trending in survey results that we're seeing. Obviously, we have Nursing Home Compare, and we should be looking at our CASPR reports on a regular basis. It's good to go back and review your surveys and see if you've got any citations that are repeating. Obviously, you want to follow up on your plans of correction, speaking with the people, speaking with resident and family councils. One area that I think really needs to be emphasized is our caregivers. We were discussing whether you include your CNAs, or do you have a group lead CNA maybe. CNAs are right there noticing the tiniest changes and can be a really great source of information or thoughts on, hey, maybe we need to look and see if we have a pattern of something going on. Again, we're keeping the residents in focus. It's got to be person-centered, and remember that this is their home. Next slide. Sort of another layer of the process of identifying our gaps and opportunities. I mentioned looking at themes or trends or patterns. I love to look at patterns. I guess that's why I ended up where I am with quality, being kind of the sleuth of what are the patterns and where are they leading me. often will choose to focus on the high risk, high volume, or problem prone areas. But you may find some that are going to be critical that may not necessarily fall into those areas, but that you feel like you need to address anyway. And again, celebrate your wins, your progress, and keep that cycle going. Let's see. I think that's it for that slide. Let's go to the next slide. So we mentioned earlier loneliness, and the colleague of mine that put this deck together really wanted to stress the effect that loneliness has had, especially over the last couple of years. But when Dr. Jurevich mentioned the survey, the social isolation survey, and that 60% or so reported some form of loneliness. I'm sad to say it struck me as almost low. I think COVID, certainly had an enormous impact, but I feel like I saw lots of loneliness, even when I was in the homes that I was working out in, and a lot of it would, is continually bringing it back to the fact that this is their home. This is where people are living, and would remind folks that, that they're spending 24 hours a day here, and they're not your job. They're people that you're working for and supporting, and that social is so critical, and how it can affect their care. There is a source, I think McKnight's, mentioned a researcher that came from Brigham Young University that said that loneliness is a greater impact on health than smoking 15 cigarettes a day or obesity. Next slide. So because we've covered it, because I feel like there's such a great overlap between our data analysis and collection and identifying our gaps and opportunities, I kind of
share an example of a performance improvement project that I led last year as a way to describe how we identified gaps and opportunities in order to launch the PIP. So last year's PIP focused on improving hydration in our residents. As Dana mentioned earlier in one of the slides, quality assurance is measuring compliance with standards. So how did we identify that hydration was an area to improve on? And how we did that is I reviewed our nursing home care compare 5-star quality measure data, and I identified that our urinary tract infection quality measure was high. That quality measure, you want the percentage to be low, and ours was about 7.7, I believe. So that was one quality measure that we could focus on to improve resident quality of life, as well as our overall quality measure score. So I also gathered data from daily clinical huddles, as well as UTI rates and trends from our infection prevention nurse, just to get a, bigger look at if this really is a big problem or not. We looked at the resident level quality measure report, which is a CASPER report, and identified specific residents that were triggering for the quality measure. One specific resident was having recurring UTIs, so we focused on interventions for that resident specifically and made those interventions resident-centric. And that helped our overall UTI incident rate, but we did note it was a good opportunity to implement process improvement, which is the second half of QAPI. So PI is continuously improving processes to meet standards, so it's proactive. So what we did is we deployed a PIP team and identified one way we could decrease the risk of UTI is by improving resident hydration. So a small team of us reviewed resident intake. We calculated the average daily intake of fluids by week for our residents. And we found that almost half of our residents drank less than 1,000 milliliters a day, which is not great. So we set a goal of increasing resident fluid intake to 1,500 milliliters a day. And we got that number from the MDS, and that's the suggested daily intake of fluids for residents in long-term care. And we then launched one intervention at a time to assist in increasing the daily fluid intake of our residents. Some of our interventions were daily hydration rounds, determining standard times in which staff should be offering fluids. So like upon rising, anytime they're toileted, when you answer a call light, during med pass, bedtime, anytime they're in the common day area, they should have a drink. So then next we educated on that standard, as well as the breakdown of how many milliliters the resident should drink each shift in order to reach that 1,500 milliliter goal. And then all of this was reinforced during our daily huddles, staff meetings, and then my PIP team also reinforced this one-on-one between each other on the floor. And we gathered data, I think, for about 3 months until we determined our interventions were effective and that we had incorporated it into our daily practice. And then prior to this PIP, our UTA quality measure was 7.7. We set our goal at 2.7%, and currently we're at 1.5%. So it was definitely successful, and we were able to move from that quality assurance, which is reactive, to the performance improvement aspect, which is proactive. Yeah, so just in summary, to identify the gaps and opportunities, make sure you're looking at real-time data as well as trends. Utilize your nursing home care compare 5-star rating data, that's huge, as well as MDS, and then make sure you're talking with your staff.
Hey Dana, this is Crystal from Mountain Pacific Quality Health. And this question is for Katie. How did you involve your family members?
Well, in this specific PIP, I don't have a specific example of how we involve family members, other than just reinforcing to the staff to be offering fluids to the residents during those specific times, and then also passing that along to family members when they're coming to visit, and making sure that they always have, they're always offered a beverage when they're visiting with their loved one. I think that's the best way of incorporating family members into this one.
Yeah, and of course, family members aren't shy about speaking up about a changing condition either. And so I think as we continually educate them, and let them know, we're kind of keeping an eye on this, you'll get feedback on the floor for sure.
Yeah, and I guess we did, with that one specific resident that had recurring UTIs, we did involve the family member significantly while we were intervening with that, just to keep them up to date as to what we were doing.
I would add, Don Jurovich here, from a geriatrician's perspective, one of my colleagues, John Morley, from the Gateway GWEP, which is one of our sister facilities, has always said that, in long-term care, the providers can deal with things like high sugars, and like, you don't have to restrict people's diet. They can be on a regular diet. We always get into this mode of, what people can't do in long-term care and not really have what they can do. And so, for instance, even like with fluid restrictions, we get some of the heart failure patients that say, you have to be on 750 cc's a day. And well, you know what? I mean, if they're responsive to diuretics, I mean, if they're on the 1,500 milliliter protocol, we can deal with it. We'll just have to ramp up their diuretic a little bit more, or something to that effect. So I think it's important to point out that one of the barriers to some of these interventions are always dietary restrictions and fluid restrictions, and I think we need to be mindful that in partnership with the provider that we can really handle a more positive global intervention to ramp up hydration and enjoyment, meal enjoyment. I mean, that's a big thing. So a little bit, I mean, I know people are on the low glycemic diets, but that's not for everybody. So
this is Renee from Montana, and I just wanted to add that when I was an administrator, we also had a performance improvement plan such as this, Katie, that you're talking about with hydration. And one of the challenges we tried to involve families, was that they sort of saw themselves as the volunteer to be able to provide liquids to lots of residents, because they know them, because they come in. And the problem is people had different swallowing abilities, different textures that they were, able to deal with. And so we got into some issues there. And so I don't know, there's just that fine line when you're involving the families and they're trying to be helpful with other residents, not realizing that there are some limitations involved. Just wanted to point that out. Don't know if you had
Yeah.
that.
Yeah, and also I think it's an important point of information that typically older adults with memory impairment due to Alzheimer's do not have a sense of smell. And a lot of times appetites and things, since we're on the topic, are driven by the sense of smell. And so the food, may not be as palatable, or like I say, Renee, the idea of texture may be a more important element for them. And, so all that has to be taken into consideration. Is Allison with us? Yeah, I think you are, Allison. Do you want to mention anything about your tracker, your performance tracker? Thank you for putting that into the chat.
Yeah. So we're currently using this one right now. We had a recent COVID outbreak in our building, so we're working on some measures there to help mitigate that. And so we've used this several times now, and just looking at those specific times when we've had outbreaks and focusing in on a couple areas that we feel may be contributing. I just think it's a really great tool. It's super easy to use. You just enter in your audit data, so you don't have to have the whole form in there. You just enter in, the number of observations you've done, and it gives you a percentage. So you can set your goal, and then, monitor your performance on whatever time frame you're looking at. We're doing it week by week right now. You could do it month by month. And then, like I mentioned, there's the tab where it auto generates those graphs for you. So just a quick way to reference your progress, and your goal line is there, and you can see how your numbers are looking over whatever period of time you're looking at. So it's a really awesome tool to use, and we've really benefited from utilizing it. So
that's good to know. Thank you, Allison. Just out of curiosity, who becomes your data collectors? Who's got marching orders to collect the data?
So it's kind of a group effort between myself, our infection prevention nurse, our quality nurse. We've got some staff nurses that have helped to do some auditing on the floors, our nurse managers. We've got our coding, ICD-10 coding nurse doing that as well. We're also trying to look at like a secret shopper where we could have somebody come in after hours or on the weekends, because everything when we're there and they see us, things get done the way they're supposed to, it seems,
right.
Typically. So it's those times where we're not present. We want to see what's really happening. So kind of, like I said, a group effort. We try to get lots of people involved, so it's not just one person, and then collecting that and then just plugging it in. Another point on that too that we try to do with our routine like survey prep through Abacus is trying to have somebody audit from outside of that department. So it's not somebody within the department who's kind of got, a bit of a bias or whatever, like, oh yeah, it's okay. We kind of do that all the time, where you have somebody coming in who has no, maybe not knowledge, but at least the basic knowledge, where they're going to say, yep, this is how it's supposed to be done. These are the points that I'm looking for. So you're getting a really good, accurate picture of what.
Today, we started out with, it'd be nice if they asked me how I want to live. Yay, Dr. Jurovich, just recently you asked, what do you want to do with your life? Someone was shocked. It was amazing. We've talked about being proactive, regular diets. By the way, I could maybe bring this up next time. The new dining practice standards came out in 2011, and they really guide us in helping people eat what they want to eat. And notice how it all goes together: eat what you want to eat, drink what you want to drink. And I mentioned this before, we have a tool called the Artifacts of Culture Change. CMS actually funded it in 2006. I happen to be the subcontractor. It's really a tool that tries to capture changing a philosophy from institution to home. It's educational. If you just look at it, you'll learn. There's 134 practices on it. Hopefully it inspires people. We've seen that. Like, hey, let's do that. It becomes a self-assessment. You can do it today. You can do it a year from now, benchmarking goals. I'll take the next slide, please. And it's a way to gauge your progress. We did a 2.0 version in February last year, if you're interested in using it. And we changed the way you tally whether you have culture change practices fully implemented, partially implemented, or not a current practice. Next slide, please. So it's really a true picture of what you have and what you don't have. And I just wanted to share this with everyone. Artifact 133, the home uses non-institutional language in all documents, clinical charting, job descriptions, policies, procedures, and verbal interactions, and provides periodic training to all team members to remove institutional language. So just thought it would fit a lot of our talk about language. You can go get the Artifacts tool. And I think, do I have another slide or not? With that, one team I've worked with in Wyoming took on language, and they created a really positive way to reinforce when people use the new language that you want, you get your name put in the jar, and then there's a drawing every so often. So with that, let's all try to get some words out, shall we? Get the